Welcome to the What About Rural Health podcast, a place where research, policy, and real life stories come together to ask the critical question: what about the communities too often left behind? I am Chinasa, a development and global health policy strategist. And for me, this work is personal. From the village health workers struggling with limited supplies to the mothers working miles for care, their stories shape the policies we need. Join me as we uncover challenges, spotlight innovations, and amplify the voices of those at the heart of rural health systems. Because every community matters, and it is time the world listens. Hello and welcome. This is Rethinking Rural Health Financing on What About Rural Health. You are listening to the podcast that asks the question too many people forget. What about rural health? I am your host, Chinasa Imo. Together we are uncovering the stories, challenges, and innovations shaping healthcare in overlooked communities. In this series, we ask hard questions about how money moves, who gets funding, who gets saved, who gets served, and who gets excluded. From policy to practice, we explore what healthcare financing should look like for everyone. How many of you have worked on a health project that ended because funding ran out? For many, when we talk about rural health funding, what often comes to our minds are government health projects or grants or short-term wins. But what we don't talk about enough is sustainability. Why do rural health systems continue to remain chronically underfunded? Why are communities burdened with the task of surviving on pilot projects? And why are we funding models that are never designed for long-term care and still expect them to hold rural healthcare together? Today's conversation is about bridging that gap. We would explore to understand why current funding mechanisms are failing rural communities, to what it actually takes for communities to build sustainable, community-rooted funding model that outlive pilot projects. And that is where my guest comes in today. But before I introduce my guest to you, let's take a quick break. If you are enjoying this conversation, don't forget to subscribe to What About Rural Health on all podcast streaming platforms. We are on Spotify, Amazon Music, Apple Podcasts, Listen Now, and so on. And yes, we are on YouTube too. Your support means a lot to us. So please like, leave a comment, share, but most importantly, drop us a review. It helps others discover this important conversation. All right. Welcome back to the episode. You are still listening to What About Rural Health with Chinasa Imo. Without much ado, let me introduce you to my guest. Tariah is joining us today. Tariah is a communication and development specialist who has spent over a decade working at the intersection of advocacy, policy, community engagement, and health system. She's worked across subnational, national, regional, and global level, whether it's coordinating emergency response during polio resurgence to advocating at different stakeholders' platforms such as the World Health Assembly, or supporting community-level campaigns that reach millions of children and tens of thousands of women and girls. She amplified their voices to engage in policy designs that improve their health outcomes. What I appreciate most about Tariah's work is that she understands that funding is not just about money, but it's about power, it's about priority, it's also about having voice. And that's exactly what we are here to unpack today. So Tariah, welcome to What About Rural Health?
Thank you, Chinasa. And What About Rural Health? It's an exciting platform, and it's great to just be here. And looking forward to having a conversation that I'm hoping will not just continue to the discourse, but would actually tweak how people see rural health.
Thank you so much. So let's dive in. So when you zoom out and look at rural health funding across contexts, what makes the current system fragile and often unsustainable?
I think there are many, there are multiple layers of issues, right? But I'd like to dwell on misalignment. Why I'd say that is rural health funding is often designed around project circles, political circles, also donor priorities, rather than around rural systems themselves and how rural systems actually function. What do I mean? Most funding are short term, as we've already said. These short term fundings are earmarked and they're activity driven. They are not centered within the contextual issues that rural health faces. And so this is what causes the fragility, in terms that it is designed to respond and not stabilize. So rural health continues way after the emergency. It's a day-to-day thing. So the way the funding is not designed to stabilize the system, it's designed to respond. And that is at the core of where the fragility in rural health comes in. And so that funding is actually activated, for example, when there's an outbreak, when there's a humanitarian crisis, when there's a failure, a visible failure. Rural health is quiet when nothing. It's when it goes back to routine, it's not visible. And it's that lack of visibility that is not put into the planning process that causes the fragility in rural health, I think.
I absolutely agree with you. And while you were talking, I remember someone in Niger State, and I think both of us worked in Niger State as at that time. And one of the officers there told me and say, you guys, all of you, these international development people, that always who's in here and want to solve the problem right now and then, like you are always and often too much in a haste to deliver this fantastic idea that you don't sit back to consider, does this community need it? Is it a priority right now? How do we fit in within capacity of those who respond to the routinized health system? I had that long conversation, but the question that I want to throw back to you is, if we know these things on ground, why do you think that rural health systems still continue to rely on this short-term or emergency funding?
I think that, there are a number of issues. One, rural health itself do not have the physical space for that. Two, also, I think there are a lot of program designs or even budgets are designed outside of the people themselves who matter. What do I mean by that? I mean that, for example, budgets are often planned annually, while rural health is rural health is daily and is ongoing. I also think that decision makers have a way of underestimating what it takes to run rural health and how to reach the underserved in the most remote communities. I think also short term feels safe.
I agree.
I think there's
I agree with that feeling.
I feel like short term wins feel safe than long term.
Yeah, because you can, there's something to measure.
There's something to
There's
measure.
something to say, this is what we
This is
just
what we
did
have
right
done.
now.
And so we continue to play the safe game. I think also emergencies create urgency. Routine care doesn't. And that prevents people from designing. And I think it starts at the design level. Also, I think it's because there's also so much external funding. And these external fundings, like we've established, are around project cycles. I think also we need to also look at how government frameworks inform funding. Like we all know, we have the health strategic plans.
Yeah.
Even though politics and political office holders are around circle, how are the health strategic frameworks really being implemented, because health strategic frameworks are designed for like 5 years, and then they're carried over
and they are static.
Meanwhile,
rural health is lived experience.
Those are lived
every
experiences.
Day. Yeah.
And so some of those things that get into those plans are not planned. And so health budgeting, rural health financing has to be flexible. It is that flexibility in planning, in budgeting, that continues to make rural health underfunded, and which means that communities, women, children, girls are left behind.
This is a whole lot to unpack that you have just described now. And one thing that I got out of your explanation is that when health system generally, whether rural health or mainstream health, is being structured as project-based design intervention, right? What that means is that it's kind of like deprioritize the ability to look at a system as a whole. And a system, just like when we are taught in biology, it's a living thing.
Yes.
It breathes every day. You need water to water, you need food to breathe, and that system continues to live. And you just mentioned women, children, and I'm just, in a way, I took my mind back to having these people as the community. And what I mean by community here in definition, it could be a location, but it could be a demography. Just like you'd say, women. Women is a community of people who have specific specific health needs that needs to be targeted, wearing that cap in mind. When they don't feature into these static, whether long-term, short-term, or immediate plans that we design at the state level as project-based, when they don't fit into these plans properly, how do we begin to say that we can actually measure that the funding we put in, or the absence of funding their needs, is sufficient, to give us not the desired outcome, but the actual outcome that needs to come out from these interventions? Because when it's intervention, it's not carrying them along already. So how do we now say we are achieving anything?
I think, that matrix is a combination of several things. But for us to actually say that we are implementing projects that reach the people themselves, we must implement projects that are priorities. And outside this example, we're implementing a project in Niger State when I was working with the other organization where I was. And our advocacy was around increasing health workers to a facility, right? But when we spoke to the women, we realized that the biggest problem for them was that there was no water in that health facility. And that sometimes a pregnant woman is asked to come with her own keg of water.
Oh my God.
To a health facility. And that sort of was the biggest problem for the women in the community. But there we were, advocating for more health workers to that health facilities. So you can see in this short story how misalignment, how not bringing the people themselves that you serve into project design. So we had done the advocacy, government had responded, we still did not see the numbers go up. And when the numbers were not going up, we had to ask the critical question of what really is the problem, if the health worker is there, if the facility is open. And then we realized that it was water. So for us to actually then say that we're reaching the people, we're not just ticking boxes, we're not just getting our project indicators or national indicators, we have to design projects that include women and voices and agency for women themselves to be a part of that process. And I feel like a lot of times in this space, we have buzzwords that we use.
We use that a lot.
We have buzzwords that say community participation. But the real question is, are communities really participating?
Mm.
And if they are participating, how are they participating? Are they co-designers? Are they decision makers? Are they beneficiaries? When we listen to them, do we actually just listen? If we even listen, do we listen or do we take... So it's one thing to listen to people, it's one thing to hold those dialogues, but it's another thing for those conversations to translate into the actual design. I think we can only say the indicator for success, it is the impact it has on the people that it was designed for. It is not that we have marked some indicators, national indicators or not. The real indicator is the woman in that settlement that has got healthcare, that has access to quality healthcare. The real indicator is that child who received care and so is prevented from certain diseases. The real indicator is that a man can walk into a health facility and receive care. That is the real indicator. And so the only way we can actually say we're successful is to go back to the people and ask them the real question: are you satisfied with the health system?
I agree absolutely with you. And what you just told me, since we are using Niger State as example, I remember, I think you were part of that mapping that would needs
assessment.
We call it needs assessment and priority mapping. And I can remember we invited community leaders, youths. It was a whole, lot of exercise. And I'm not saying this with any resentment. The community people were telling us exactly what they needed. The leader, we had the king, their local rural king. We had the women themselves, we have the youths, and we put them in work groups for them to map out exactly what they needed. But I will tell you for a fact that some of what they had told us got lost in translation. And this translation is okay, you have repertoired all of this thing and you send it to the consultant or the expert who is probably sitting in a cool, air-conditioned office in Abuja and looks at your reports and condition everything that this community has said into the milestone, the indicators that we want to achieve, not what the communities want to achieve. Now, when you come back to implement that, and the community are like, nah, this is not what you waste our time to do, right? How do we then buy in to this when it's not reflecting our voice anymore?
Yeah. I think that brings me to an important point, which is community trust.
Yeah.
The bedrock of health service delivery is the trust of the people you're trying to serve.
Yeah.
And I think that these kinds of scenarios have far-reaching impacts, in the sense that after a while, communities then feel like their voices do not matter. They come to this meeting out of courtesy if they come. And if there's honorarium, they probably just come. But they are not really participating anymore because they've seen 1, 2, 3 times where their voices did not really matter when it came to the real design, when it came to real decision making. And which is why I was speaking to buzzwords like participation. What does it really translate to? What does that mean in action and in reality? And so this goes beyond, I'll give you a simple example. Recently, I've been leading a project in northern Nigeria, and it's a polio project. And some women, some households had refused vaccines. And we went to ask what was the problem. And the problem was that when malaria program was distributing nets, they sort of mapped out that community. But there was no communication, there was not engagement with the community to sort of provide feedback as to the matrix that was used for mapping that particular community out. And so when polio campaigns came, the communities rejected the vaccine on the grounds that when it came to malaria nets, we were
didn't see it.
excluded. Now you're bringing polio vaccines to our doorsteps. So the far-reaching, what I'm reflecting to here is a far-reaching impact of that sort of lack of participation and trust. So this is something that's done by one program, but is impacting another program. And it's going to impact those children, and it's going to go back again and impact probably another project. This is what happens when communities cannot trust the health system again. And I think that as program managers and as advocates in this space, we really need to actually think and sit back and think about what community trust is.
I agree with you.
And how community trust is leveraged for implementation of programs, for buy-in, for acceleration, for impact.
Great.
Community trust is continued to be broken in the way that we design projects, in the way that projects are implemented, in the way that feedback is also given. And so the far-reaching impact of this at the end is a child who probably not receive service, is a woman who probably not get the quality of service or the desired service. And those are real life-changing things. And we must begin to then consider how these things actually affect the system.
Thank you so much for providing clear context to this conversation. I think we should give our audience a minute to digest all of these things. But listeners, while you are reflecting on all that we have discussed so far, I want you to think about your own community. How many of you have seen strong programs struggle because funding cycle didn't match community needs? While you are doing that, we'll take a short break. When we return, we will pivot to discussing financing. Do you have a rural health story that needs to be heard? Whether you are a health worker, a patient, a policymaker, or an advocate, we want to hear from you. Share your story on our website at www.whataboutruralhealth.com/stories and help us amplify the realities behind the data. Someone from our team will contact you with details on how to get your story published on our newsletter, website, and other media platforms. Welcome back. You are listening to What About Rural Health with Chinasa. So, Tariah, you've worked directly with communities and health workers. What does underfunding actually look like in people's daily life?
I think that's a very important question. Because sometimes underfunding it depends on who. And underfunding could just be, we didn't have money for this. But what does underfunding look like at community level? Underfunding, I think it actually looks like a health worker who was trained was not posted because there was no funding.
Yeah.
Underfunding looks like a facility that does not exist or exist on paper. It exists on paper, but it's not able to provide the quality of service that community will need.
Yeah.
Underfunding also looks like outreaches for vaccination, outreaches that will not happen. And what that means is a child that will not receive service. Underfunding also means that a lot more people are paying out of pockets. A lot more people are going to pay out of pocket for that service. Underfunding also means that a woman is going to absorb the gap of underfunding. For example, I give a typical example. Where an outreach is not possible, it means that a woman most times will take a child and probably go extra mile.
Yeah.
Which means it has impact on her life, on her time, on her day. That is what underfunding really, truly looks like. And as we talk about underfunding, right, I feel like we need to connect underfunding to real life stories to actually then communicate this impact.
I agree.
Because for someone sitting in a fancy office in Geneva, underfunding is just, we don't have money for this.
Yeah, that's true.
For someone who sits in a fancy office in a state capital or regional office, it's just a line item that was not funded.
And there's nothing we can
do
do
about
about
it.
it.
But really, underfunding shows up in the community also as lack of trust.
That's true.
It also shows up that we cannot trust this health system because today we have service, tomorrow we don't. And so we have to create alternative. Underfunding can also mean self-medication. So it plays out in different ways. But really, when we say underfunding, we should have at the back of our mind what it means is that someone somewhere will not receive service. It's as simple as that. And that's the burden we must carry as we go through this. It goes beyond a line item that wasn't matched to a people whose healthcare needs were not met, will not be met, and are not met.
I don't want to say I absolutely agree with you, but I do, because all of these things that you have layered out here, and I meant to ask you like a follow-up question, like how does this affect women, girls, and children? But you've answered this, and while you were answering, I remembered the last conversation I had with one of my guests in the Instagram live. Her name is Crises, and we were talking about the impact of like menstrual health hygiene on young girls who live in rural community. And literally what you say is, what she come up with, like when girls do not have that confidence that they would be able to either afford pad or access pad because there's a support or assisted system that provides pads to them, then they choose to boycott the health system entirely and then work within their peers to figure things out. And figuring these things out means using unhygiene clothes to wage the blood when they are menstruating, when they have pains, and you know what that means when you manage menstruation with unhygiene materials, it produces other forms of health care, issues and challenge that these young people may face. But when they now face this other thing, they are still not able to trust the health system. So it's not just no more about not having access to, it's not more about not having access to pad, it's not more about pad poverty, but it now linger to other kinds of ailments.
I absolutely agree. When services disappear, women don't stop needing care.
Exactly.
They absorb the gap.
Or they choose alternative way, like alternative medicines.
We really need to rethink that. Rural health is about people.
Yep.
And people continue to move on. The question is, what are the alternatives? Because people's lives do not stop because health services disappear. And women absorb the gap of what this is. And how does it then translate? Because health, there's an intersection between health and other things in a woman's life. And those are really, really, really critical. And it's sometimes when you work at the community level, right? Because you get to see it. You get to hear the lived experiences. You get to see it. Health services, providing health services, advocating for health services goes beyond a job.
And I just want to uplift the people who do this work on a daily basis. I mean, we can talk about all of the things that are not working in the system, but people still wake up every day, shower, take the risks to go to some of these rural communities where security is porous, access is difficult, but they show up every day. So I just wanted to pause and do a shout out. But I want to redirect this to you. I mean, while I was reading your bio, I see that you started off from radio. That means you were like an AOP or some celebrity of some sort who hosts some program in our daily morning shows. And then suddenly you move into development and policy advocacy. How did that shift? One is, why did you make that shift? And then the second question will be, how did that shift change how you think about rural health funding and health intervention generally?
I think I'll start with why I made the shifts. First of all, radio was something I really loved and enjoyed. It was something I had dreamt of for years. But working in radio taught me that voice is important to drive change. And so it was very deliberate to make the move. And why did I make the move? It was to ensure that people are situated within decision making corridors. Because on radio, I was anchoring programs like Girls Talk that really talked about things that women and girls faced. And day in, day out, I got to hear lived stories. And so the question I did ask myself was, how do I then enable change? I think you asked something about
How did that shift change how you think about rural health financing and health intervention generally?
I think how that shifts changed how I see rural health intervention is. So communication, radio, um, can actually decide what is important, what is urgent, and also what is investable and who can be trusted. Because on radio, people wake up every day, they trust that you will be there. They trust what you're saying, so that you're going to show up. They're going to tune onto your station and just listen to you. And for some people, you meet some people as a radio host and you've never met them, but they feel like they have a relationship with you. And what that taught me really is that voice was much more powerful than I knew at the time. And so communication for me became how I could amplify voices, and also sort of take those voices into the rooms that matter, and the evidence and the voice can then support um, how policies are designed. And I'll give an example of how this has worked. When we worked in Niger State, we had this campaign on what women wanted, right? And we asked women what was it that they really needed. And we had done a documentary as part of our communication tools. And this advocacy had been going on for a while, but we didn't get much response. And then we had this premiere for the documentary where we had invited high-level key stakeholders. And the documentary was aired. The Commissioner of Health was actually crying. He actually broke down. This is someone who had been commissioner for years. But watching those stories just broke him and he was crying on spot. What that meant was, for me, I could really just watch how voice, how communication can decide what is urgent, what is investable, what the real issues are. And in the way that I see rural health, it's how you can use communication as a tool to translate voices from communities into the rooms of policymaker, into budget design, and into policy frameworks.
Thank you for that response. And when you were just mentioning radio, and I look at myself and say, I'm a podcaster. The whole essence of like running this What About Rural Health is to drive traction to rural health issues. But it doesn't just stop there. I wanted the ability to bring thought leadership to discuss how investment can be possible within rural community, how people who do research can trigger interest to really look into core rural health issues and produce evidence. Because now, like you mentioned, voice match evidence equals to decision. And if you can bring out emotions like you brought up from the Commissioner of Health, then there's a high likability. At least what is plausible is possible, right? So there's a likability that emotion
Matched with evidence.
matched with evidence will produce action, because the right decision maker is seeing the evidence right before
It
you.
did produce a kind of results that we had spent years and did not achieve. Because one, if you produce interest, the policymaker became interested. So what is this problem? And went down to the community himself. So that's what communication can do. And I think that's what your platform is also doing. Even this conversation we're having, it's situating our experiences within those within conversations like that. And I think that's what's beautiful about communication, is that it can translate, it can make change happen.
That's true. But I want to pivot a little bit more to talk about communities themselves. What role do you think communities would play to sustain rural health delivery system? Because like we can bring all of our tools, and advocate even to the highest level. But if communities are not matching action with these efforts, I don't know what that would mean.
I think that I've worked at subnational level in Nigeria. I worked in some countries in Africa, and one thing that stands out is that communities themselves need to stop and think about what is their place in health service delivery.
Yeah.
Communities need to stop seeing themselves, stop waiting for help to come. I don't think that we can have these conversations. We can do advocacy. Governments can even increase budget lines, and can even improve. However, I think the people who need help the most must themselves begin to initiate some of these things. And that what brings me to blended financing. I think communities themselves need to actually then ask questions like, what are the real problems in healthcare service? Is it the health worker? Is it financing? If it is financing, what is our role in financing? And I think that until we begin to have conversations that situate rural health, not just as responding, but as stabilizing the system, as a system, I don't think we will make more change. We will continue to see these kinds of scenarios. And so communities must then become change makers themselves. And also not just like a buzzword, or communities must actually put money where it matters. And many will argue that, these people are in rural communities and they might not have the financing that it will take. It depends on how you see it, but I don't completely agree. For example, I think that a community can contribute $1 a day, $1 a month, $1 a week in Iran, where whatever it is, towards solving one particular problem in their health center in their communities. Communities can also themselves amplify voices. Communities can demand to be part of the conversation. Communities do not have to wait to be invited. Communities themselves must be interested in the health service that gets to them.
I agree.
And I think in some communities we might see that, but that's not what's obtainable across board. And I think that's where we need to pivot to. We need to pivot to having communities, citizens who begin to see themselves as part of the process, who do not see themselves as waiting for a savior to come and save them, because there's no savior coming. There's no Santa Claus here. This is real life. And you have to be a part of the kind of service that you want. And I think that's what the entire conversation of ownership is about.
Thank you. Thank you very much for joining me in the studio today. I would say that rural health does not need more short-term fixes. It needs sustained commitment, trust in communities, and funding models that match the realities on ground. So, to everyone listening, thank you for joining us on today's episode of What About Rural Health. If today's episode moved you, challenged you, or made you think a little differently, Please follow, subscribe, and leave us a review on our favorite podcast platform. And as always, let us keep asking the question, what about rural health? Until next time, I am still your host, Chinasa Imo. Bye for now.